Welcome, everybody. Welcome to the Stanford Center at Peking University, and welcome to those joining us online and those who might be viewing the recording later. My name is Karen Eggleston Bengsheng He, and I am director of the Stanford Asia Health Policy Program. And it's my honor and delight to welcome you today to our inaugural event in our ongoing colloquium series, starting this year, but continuing our collaboration with partners here at Peking University, Peking University's Institute for Global Health and Development. Today, we're delighted to have several experts talking about advancing healthcare, technology innovations, and policy perspectives. We have multiple experts sharing their expertise on this topic with us, although unfortunately, Director Yu of the Zhejiang Provincial CDC is unable to join us today due to urgent commitments. So to introduce our distinguished panelists and to moderate the discussion of the panelists after their presentations, I'm delighted to turn it over to Professor Yuhang Pan from Peking University Institute for Global Health and Development. Professor Pan, over to you. And welcome again, everyone.
Thank you so much, Karen, and thank you so much for joining today's events. I'm so happy to host. It's my great honor to present today's three distinguished presenters. And the first presenter, I think, will be Professor Lei Xiaoyan from Peking University National School of Development. Professor Lei is currently the Changjiang Scholar Professor of Economics and PKU Boya Distinguished Professor. She's currently the chair of the academic committee of the National School of Development, as well as the party secretary. And she's also the director of the PKU Center for Health Aging, and she has been published a lot of papers in the fields of health and it's widely like public policy related issues. And so, Professor Lei, over to you. Thank you.
All right, thank you for having me here. I would like to introduce a little bit about our paper just recently written. It shows how the broadband China policy affects the well-being of the elderly, including health and other outcomes. So the motivation of the paper is that digital connectivity has been developed so much in China. It has reshaped the societies globally as well as China. It may have potential to impact elderly health. And for internet access, as of 2023, 64.4% of the global population had internet access, averaging over 6.5 hours online daily. So there may have potential impacts on elderly health. The evidence have been mixed. There may be positive effect because the technology may increase social integration, maybe have mental health support and real-time health interventions, which may affect the health of the elderly positively. However, it may have a negative impact because the technology may cause internet addiction, may provide misinformation and social isolation. So there is critical need for empiric investigation on that. So in this paper, our research question is how does broadband China internet access affect the health of older adults? We utilize the standard rollout of the broadband China policy and large-scale survey data to include the causal effect on mortality, physical health, mental health, and cognitive functioning of the surviving. We also use event study and DID models to do that. And we also investigate potential mechanisms, including community-level social support services and other factors, such as health behaviors and family dynamics. So the contribution of this study may have three perspectives. One is it provides robust causal evidence on the impact of digital connectivity on elderly health. Second, it investigates the impact on transformation of community-based elderly support in addition to the internet access. We also provide policy insights for mid-income and developing countries. So institution background of broadband China policy, the Chinese government led broadband China policy during 2014 to 2016. During the 3 years, it had the 3 phases reform involving 117 cities. So each year it added 39 cities. So the achievements of broadband China, it increases network coverage and the speed, and it also increased bandwidth capacity, and also digital inclusion increases and the cost decline. And by 2020, 93% of households had optional fiber connections and 90% fixed broadband penetration. And it increases access to healthcare and community services. And also it provides age-friendly digital products. So the data we used is the Chinese Longitudinal Health Longevity Survey, which was conducted by Professor Zheng Yi in our department from 1998. And I started to take over from 2015, helping Professor Zheng Yi to collect the following waves of the data. And it is a comprehensive data set of Chinese adults aged 65 and above. It covers 23 provinces before, and in 2021, the most recent wave, it expanded to 27 cities. We just focused on 2008 to 2018 waves and construct 2 key data sets. One is the mortality data set. Each wave, we collect the information for those who have died during the between the previous wave and the current wave. So with that information, we also ask family members about the detailed information about the dead person. So we can create the yearly data a panel data of the elderly people. Each year we know whether they died or not. So that's the panel. So from 2009 to 2018, we have more than 67,000 observations. The average age was 87 and 45% being male and 41% literate and 35% residing in urban areas. And we also have detailed information about their health status each wave. For that, we just do the wave by wave panel covering years from 2008 to 2018. Those 4 waves, totally nearly more than 50,000 observations. We link this CLHLS data to city level information on the BCP broadband China policy implementation. Okay, so we have remember we had this policy during 2014 to 2016 with this data set. We can do before and after, and we have enough information before the policy, so we can also do pre-trained analysis. So the variables, the key variable is 1 year mortality. We also segregate that into mortality with severe diseases and mortality without severe diseases. And we also have the other sets of health status for those who survive, including ADL, IADL, mental health, and cognitive functioning. And in order to explore the channels or mechanism, we also look at the social support, individual behaviors, and the family dynamics. So we use standard event study model. I will skip this due to time limit. And we also do DID for the health status analysis and the 1-year mortality. So in order to address all of the potential pitfalls, we do various robustness checks, and I'm going to skip this as well. So here is the key result. The top one is for the 1-year mortality. As we see, this is the year when the city has this policy implementation. And here is the 1 year before, 2 years before, because the cities have this policy during this period, maybe in 2014, 15 or 16. So we have different time, but that could be for specific city, it's 0, no matter when they have that policy. So that year should be 0. This is standard thing for event study. And here is when 1 to 5 years before the policy for that city. And this is 1 year after, 2 years after, and 3 years after. So it clearly shows that BCP reduces 1-year mortality. For the first year, it declines by 1.4 points or 10%. Second year, it's about double. And third year, nearly triple compared to the first year. And the average reduction is 2.4 points or 18%. And for we also do that for those who died with severe diseases or without severe diseases. It is clear that it works mainly for those who do not have severe diseases. So for people who have very severe fetal diseases, they may not help. But for those who have not severe diseases, they can help them survive. So that's the main effect for mortality. And then for health outcomes, here we have multiple effects. It looks like BCP improves ADL and mental health, but not it improves IADL and mental health, more psychological stuff, but not ADL and cognitive functioning. Probably ADL needs more time and more effort to do that, and also cognitive functioning needs more time to take effect. And then we investigate the channel. For social support, we do one is PCI index. That's the index for all the social support. And then we do that separately for each of the items, including daily care, psychological consulting, social and recreational activities, shopping services, legal aid, health education, home visits. All of them are provided at the community level. So these are basically look at the social support from the community level. So BCP significantly increases social support from the community in various forms. And then we look at the health behaviors, including the social activities of the person, and whether they're watching TV, reading, housework, and health behaviors like smoking, drinking, exercising. And we do see BCP increases slightly on social activities, which is consistent with the provision of the social support at the community level. And we also see it reduces smoking slightly, but not other behaviors. So it's more like the social support at the behavior. And then for the family dynamics, BCP reduces relying on family members for help. That slightly, it seems like they can rely more on the community level services. They can reduce relying on family members, but not on family income or transfers. So it do not reduce or increase family income or transfers to them. So in conclusion, it seems that BCP broadband China policy has improved health status of the elderly, including mortality, and the mechanism could be more likely to be the social support enhancement. We also do some best cost-benefit analysis. It seems like it reduces cost, at the cost per life year saved ranges from 15,000 to 86,000. The range is very big because we do not have specific information on how much broadband China has been spent on the elderly specifically. So we have a very high range of we use the total cost, and we also have some information on healthcare information stuff. So that is very tiny part of the technology. So the cost range is so high, but it's more near to 86,000 yuan. And the channel is like it increased provision of services by communities, including daily care, psychological counseling, social activity services. And there may be implications for public health and the digital infrastructure because BCP may serve as a model for cost-effective public health interventions. It also shows digital technology can be combined with social support. So it may bridge the digital divide to ensure equitable health outcomes in the future. That's all. Thank you.
Thanks a lot for Professor Lei's presentation. So let me then present our next speaker. Our next speaker is also my colleague from Institute for Global Health and Development. She graduated from the University of San Diego, and later on she spent 1 year at Stanford for postdoc, and currently assistant professor at my institute. And today she's going to talk about the topic, improving regulation for innovation, evidence from China's pharmaceutical industry. So welcome, Jana.
Thanks, Yuheng. And thanks, Yuheng. And it's a great pleasure to be on this panel. So I think we just heard Professor Lei talking to us about how this kind of general technology improvement affected populate community as a whole. And so and Professor Lei's talk also mentioned that that particular technology does not actually work for those who are more severely like in a disease stage that is more severe, right? So for that part, I think we need to rely on some particular technology improvement in healthcare to be able to help those like group of people in the population. So I think for my part, I'm gonna zoom into the pharmaceutical industry and look at the innovation incentives and to look at those innovations that are helping helping people improve the overall longevity. And also for I think our third talk, Benny's talk, we are also going to talk about those kind of more advanced technology in healthcare. Right, so for my part, I'm going to talk about the impact of regulation on innovation, and I'll be looking at China's pharmaceutical industry. And just to quickly motivate this question, we all know medical innovation historically has played a very pivotal role in the advancing health and longevity. For example, historically, the discovery, the development of those kind of important drugs like antibiotics, vaccines, and nowadays anti-cancer drugs, those kind of very advanced therapy has saved a lot of lives, right? And some scholars have calculated that medical innovation have led to around 73% increase in mean age at death. So innovation is very important. However, the research on this very important issue has been mainly focusing on developed countries. And developing countries, as you might all know, even though you might not be closely following this field, is lagging behind due to various reasons, and including market failure and government failures. And we all know that the leading country in medical innovation is the US, right? And we have to say everyone around the world is benefiting from the innovation there, but we still care about the innovation in developing countries like China. So one of the barriers that developing countries facing in innovation is that the regulatory practices is lagging behind. Right? And actually many developing countries are now trying to conduct a lot of regulatory reforms to address this issue. And the one particular dimension of regulatory practice that we are going to focus on is what we are showing in this graph. This graph shows you the distribution of approval time for new active substance across countries in 2016. So the color bars are all developing countries, and the red bar you can see represents China, and the gray bars are all developed countries. And overall in developing countries, it takes longer for a drug or an application to get approved than developed countries, right? And then among the developing countries, China is also an outlier. So that you can imagine can be a very important barrier for pharmaceutical innovation. For innovation or for other innovation as well, if you need to wait for a long time for your applications to get approved. So the question that we want to ask here is that to what extent can improved regulation foster medical innovation in emerging markets? So in particular, what we do in this paper is we look at a very significant regulatory reform in China, which was carried out in 2015. And at the time that the reform is carried out, the Chinese FDA confronted a lot of issues that is a result of a shortage of proficient personnel, and also those people have kind of a limited regulatory practices that has resulted in delays and backlogs in processing of those drug approval applications, as we have seen in the previous graph. And what the government agency did is they adopted the US FDA practice, which was implemented back in 1990s. And what they are trying to do is to try to collect user fees and use that money to fund a growth in personnel, so that they were able to reduce the approval time of the investigational new drug applications. So I'll tell you more about what this IND is in the next slides, but here this graph is just trying to show you first how the approval time has been reduced, right? The dotted line represents the year that the reform was started, 2015, and it's not like a steep, like it's the reduction approval time is not achieved within a year. It takes a couple of years, but gradually you can see the reduction is pretty significant. A little bit about the drug development process, if you're not super familiar with this. So just to make it simple, we all know that before a drug can be sold on the market, it has to go through several stages of clinical trials, right? That will be tested on human, right? And then before that, there will be like lab testing. They develop the drug candidate in the lab, and then before they take it to human for clinical trials, they need to file this IND applications, right? Only after you get approved from the government agency, and then you can proceed to test it on the real population that you are interested in. So the outcome of interest that we mainly focus on is this IND applications, right? So we're going to look at the number for that. Right, as a measure of IND applications. So here I'm showing you. So before we have seen the decline approval time, that is the blue line showing this graph, and on the right line we are showing you the total number of IND applications, right? Probably you can already see from this graph that after 2015, when the approval time is reduced a lot, and then the the number of IND applications increased a lot, right? That is suggesting, even though as economists we know that correlation does not necessarily imply causality, but this strong correlation is suggesting that there might be some causality here. And that is the main relationship we are trying to explore in this project. So in particular, a little bit about the technical stuff before I get into more details is that we actually use drug level variation in the reduction in approval time and to study the impact on innovation quantity. And not only that, I think one major concern people have about the Chinese pharmaceutical industry is that is mainly imitating or following what the advanced companies are doing, right? So we want to look at the quality of innovation, or to be more precise, like the novelty of the innovation, right? So we're gonna look at that, and also we look at the market response by looking at the stock market response. And by all this exercise, we are trying to understand the barriers to medical innovation in China and other emerging markets. So a little bit on the context about the China's pharmaceutical market. It's the world's second largest pharmaceutical market in 2015. And it's still growing at a very fast pace, even though probably like the US still gonna be #1, but the market size in China is definitely growing very rapidly. And for the pharmaceutical industry, the R&D has historically been more focusing on the development of generics, right? But since 2010, we have started investing more in innovative drugs. And we can see from this graph from 2010 to 2020, the blue bar, the darkest blue bar is showing you the number of IND applications. And the IND number is growing by 30% annually during this 10-year period, even though if we look at the total number, it's still pretty low compared to the US, but like it's on this kind of a growing trajectory. But the regulatory system has not been able to keep up with the development in the industry. And this graph is what we have already seen. And just to give you a few more numbers to help you get a sense of the challenge that the government is facing. So in 2014, the Chinese FDA received around like 9,000 new applications, but they managed to complete only like 5,000 of them. So by 2014, there's like a cumulative backlog of almost like 18,000. So like there's a lot of unsolved cases there, and people are submitting in new applications and they were not able to handle it. And they start to make changes, right? And they have a target of processing time of 60 days or fewer when they implement this reform. And you can see before the reform, this is the approval time for IND applications. It's around 550 days, right? It's more than a year, 1.5 years or almost 2 years. And they want to achieve a time of like 60 days or fewer. And they managed to do that from 2019 to today, I think, right? And the way they manage to do that is like through a collection of user fees and use that to fund evaluation stuff. And there's some other like reform or policy levers to help achieve that. For example, they have penalties for data falsification if you're detected, and they also establish some clear and publicly accessible evaluation criteria for the pharmaceutical companies to follow when they submit their application. So we basically get the data from the China's medical registration data. And from that data, we can observe which companies submitted which application. And we can also observe the date they submit the application, and then like the date that they got approved or they got a response, either approved or rejected. So by using that data, we can measure the time that it takes for a particular application to get approved, right? And then like we basically compare the time it takes in the 3-year period before the reform and in the 3-year period after the reform, and then we can get a sense of how much the approval time has been reduced. right? So, and also we computed that at drug level, and we use some like a drug classification system to group the drug into categories. We won't talk too much about that. That's a bit too much in the weeds. And then from that data, we are also able to observe the quantity of innovation by looking at the number of R&D applications. That's pretty straightforward. And also we can see the name of the applicants, basically which firm is submitting that application. And to measure novelty, that's a real challenge, right? Because like how you know whether it's truly novel or not. And I think we take probably like a simplified way of measuring that. Basically look at whether the drug in development is following a drug target that is already a mature target in the US market, right? For example, if you know the drug development industry, like PD-1 is a very popular target in like cancer drugs. So if they're developing a drug with like a target of PD-1, then probably it's not that novel. If it's like developing a drug with a target that we have never seen anywhere, then probably it's not more novel. So that's our way of measuring novelty in this case. And we also use Chinese business registration data to look at whether the firm is newly established after the reform. So we want to see whether they are like more firm entry, right, after facilitated by the reform. And we also use the stock market data to look at market response. So to look at innovation quantity, right, we've already seen the correlation stuff on the left, and on the right, we are showing you at the drug level, the relationship between reduction in approval time and the increase in innovation quantity or in R&D applications. And we can see this clear positive relationship here, right? And then we use like the Poisson regression to estimate this relationship. And we're not gonna talk about the details, but we're gonna see the event study graph. So basically we can see that the drug categories that are experiencing a higher reduction in approval time, they start experiencing like a larger increase in the number of IND applications. I think after the 3 years of the reform, we can observe like a 60-day approval time was achieved, right? So that is pretty consistent with what we've seen in the previous descriptive stuff. It's just that we are quantifying it using more rigorous econometric method. And now we are trying to look at whether they are done by existing firms or whether those information are done by the newly established firm after this reform. And we can see that actually the new firms are responding more strongly to the reform. Panel B is showing you the results from the new firms. Their magnitude is larger. And now we want to look at the implications on aggregate innovativeness. And remember, we are looking at whether they are following mature target to see whether they are developing novel drugs. And this graph is showing you the share of Chinese drugs adopting mature US targets. So a declining trend is implies that we are developing more and more novel drugs. Fewer drugs are following US, right? So that's the overall pattern. We want to see how much the reform has contributed to this overall decline. So we did some decomposition exercise, and still I'm gonna show you the results only if you believe our exercise. Right, so from 2015 to 2020, there is an overall 9.2% decrease in this measure, or you can understand it as 9.2% increase in aggregate innovativeness, right? And of the 9.2, we find that if there were no reform, the aggregate innovativeness will only be increased by 5.9%. So basically the gap between the blue line and the black line are what is brought out at this particular reform. So if we do this accounting exercise, we can see that the reform can explain 33% of the post-form decline in the share that is following the mature US target. And of that overall improvement induced by the reform, actually 80% was driven by new firms, right? So the new firms are more innovative. They are more likely to focus on innovative developments. They are contributing a lot. So for the market response, because the reform is fairly recent and the development of the drug is taking a lot of time to achieve, right? So this is not kind of like we only look at the overall response of the market to the reform. So actually, if you look at the top right panel, this should actually be 2015 to 2022. There's a typo here. We can see that after a new drug is launched, the stock price has a significant increase, whereas in the period before the reform, the market does not seem to be responding a lot to a launch of the new drug. So the market overall recognized the change brought out by the reform. Right, just to quickly sum up, so I think in this research, we found that adopting this specific regulatory practice in frontier countries can foster innovation in emerging markets. And this improvement, we see it both in the quantity and quality innovation, and is recognized by the market. As for the implications, we think we find that identifying and adopting some specific effective regulatory practices can help, right? But this is not to say we should have fewer or more regulations. We are not able to say that. And then another implications of our finding is that in emerging markets, the new firms are very important for the overall innovation, but they could more easily be deterred from entry because of some entry barriers, and that could be a result from the regulatory barriers in particular. Okay, yeah, that's all from me. Thanks.
Thanks, Jianan. And let's welcome our last presentation, which will be presented by Professor Lu Beili from Institute for Global Health and Development. Beili is also my colleague. She graduated from University of Wisconsin, and actually he has 2 doctoral degrees and another from Peking University Medical School. She's currently leading the very large-scale experiments on the surgery robots in China's hospitals. And today she's going to report the survey of the project progress, I think, right? So without further ado, let's welcome Professor Lu.
Thank you, Yang, for the kind introduction. And good morning, everyone, and thank you very much for having me here. I'm from a clinical and epidemiology background, so the flavor of the following talk probably will be different from 2 economists. And this project, we don't have data yet. So today I'm going to share a lot of the thoughts that when we are designing the study. So this is the outline for today's presentation. I will briefly introduce the concept of a health technology assessment, HTA, in healthcare policy and economist, robot-assisted rectotomy, which is a very specific and practical innovation, and the objective and study design of SMART. We know that technology and innovation have made great contribution to modern medicine and human health. We can name a lot of examples, like the mRNA vaccine. Some of us probably personally got the vaccine and benefited from the technology. And most people are excited about health technology innovation. For example, in medical community, you can see a lot of reports on the innovation in leading clinical journals in basically every year on the annual conference of leading medical societies. But maybe not everyone is always excited, maybe not for healthcare systems. We know that 2 of the greatest challenges facing healthcare systems are sustainability and the efficient use of scarce resources. Innovations could be great, but usually they are very cost. It comes with a high cost. And how to balance the sustainability and the support for healthcare technology innovation, sometimes it could be challenging. And actually in global health, there's a term called appropriate technology. Maybe the technology is great, but Is it appropriate in certain area, especially low and middle country areas, when maybe people could afford it? Maybe there are bigger challenges of balancing the needs and the cost. And it would be great if we could adopt an evidence-based approach to provide high quality evidence and be better balance the need for sustainability and the support of innovation. And one such tool is health technology assessment. According to the WHO, health technology, the definition could vary slightly. One definition is health technology assessment, HTA, is a multidisciplinary field of policy analysis studying multiple outcomes, the medical, economic, social, and ethical implications of the development, diffusion, and use of health technology. People care about safety, whether the new technology is safe. Not every technology is safe, and there are historical examples showing that. Whether it's effective or efficacy, whether it's doing what the technology says it's doing, and whether it's cost effectiveness. Does the high cost come with the technology pay off by the gain, for example, the quality of life or the extra years people may live, and whether people have access, and whether the new technology, how, and whether it affects equity. Does the rich people and people of a higher socioeconomic status always benefit from it? And how about people who are more disadvantaged and have limited access to care? And for HTA, it could support coverage decision-making, optimizing the efficient use of limited healthcare resources. So it may help balance the sustainability issue of the healthcare system. And the final goal is to promote an equitable, efficient, and high-quality healthcare system. And indeed, this is done. For example, this is adopted by NICE, which is the National Institute for Health and Care Excellence in UK. And this is the agency to decide whether NHS would adopt a road reimburse and what's the reimburse rate for certain technology. There are several things they care. For example, whether it's clinically effectiveness and safety. So whether it's providing the benefit and whether it's safe. And a good part, an important part is whether it's cost effectiveness, is the money worth it? And these two parts could be, HTA could be a good tool to answer these two parts of question. And also in the broader context of HTA, people also study the ethics and the equity issue of new technology in pharmaceutical as well. There are different types of economic evaluation depending on the study outcome. It could be cost-effective analysis, which is comparing the cost of the technology, for example, versus the clinical outcome. For example, a life saved, or a disease or a complication prevented. And cost utility analysis, comparing the cost versus the quality of adjusted life years, which is a composite measure of, for example, how many more years a person may live extra and the quality of life. So, and this is the CUA. CUA and CEA sometimes are used exchangeably, and this is the most commonly used tool in policy and reimbursement decisions. And other ways to do it could be cost-benefit analysis, comparing the cost and the benefit in terms of money. And for conducting HTA, there are main two approaches. The first one is a model-based approach, which could be easy, more convenient to do. It uses a set of model-based approach, such as decision tree, Markov simulation, to do the analysis. And the second one, and which is more and more popular today, is real-world studies. So the researchers go out to the field, collect data from real-world clinical setting, and do the analysis. And for the SMART project, we will do the second one. So we talk about technology, and maybe robot-assisted surgery is a good example of technology in innovation. I put, maybe I know most of you probably are not from medical background, so I put a little demonstration. So for example, if we are doing a liver surgery, there are 3 ways of doing it: open surgery, a laparoscopic, and a robot-assisted surgery. For the open surgery, the surgeon needs to cut open the patient's abdomen, and the cut needs to be big enough so the liver, for example, the liver can be located, and surgeons can operate using handheld tools. And the second one is laparoscopic. So there are several holes on the abdomen, and there are several long, usually very long handheld tools, and they could do the operation. And the third one is robot assisted. So instead of surgeons standing next to the patient, the surgeon could sit in a console, and the console could be right next to the operating room, or even 5,000 kilograms away from the surgery site. And they could do it using more precision and usually more with the assistance of the tools. It has the potential to enhance precision and the patient outcomes. But the robot-assisted surgery, it comes with significant costs. So for example, in China, once you open it, there's a fee called open fee, and it's 40,000 yuan, whatever the later cost is. And there's also uncertainties about long-term impact. So this is a health technology innovation, has a potential to improve patient outcome, very costly, and some uncertainty. So this is a good example to do health technology assessment. And so PKU, my Institute for Global Health and Development, and we partner with the China Medical Equipment Association. We launched a survey of medical assessment for robot technology, the SPARK project, in 2023. So we want to evaluate the robot-assisted surgery. The next step is to pick a specific procedure. In the first phase of the study, we will focus the interior resection for colorectal cancer. And when we are designing the study, there are several thoughts. First, the disease is of great importance. Colorectal cancer is among the top 5 malignant tumor in both incidence and the mortality in China. So it's a disease that's worth studying, and it has a strong necessity. So there are reports in the surgeon anecdotal evidence in both reports that the robot-assisted surgery may improve patients' quality of life, but there's also uncertainties. In some cities, robot-assisted surgery has been covered by government's medical insurance program, and we would like further scientific evidence to provide for policymakers to refer to whether to expand the reimbursement and whether the reimbursement rate is appropriate. And there's a research gap. There are few relevant health economic evaluation studies in China and globally, even globally. Also, to be able to conduct the study, it is a high feasibility in this disease. It is promising, given the large patient volume, it's promising to enroll enough patients within half a year. And that's for realistic consideration. We may be able to finish the study in time and with a limited budget. So the aims of the first phase of the study is to evaluate the health economic value of robot-assisted low interior resection versus the traditional one, the laparoscopic and open surgery in treatment of the rectal cancer. And this is going to be a prospective, nationwide, multi-center cohort study, including 12,000 participants over 3 years of follow-up from a society perspective. And for example, the 12,000 participants were calculated based on sample size calculation, and I will not bother you with the details. And these are the study sites that we are working on. In total, there are 16 study sites. And from the maps, you could see that when we pick up the study sites, we aim for a diverse representativeness of geographic location and also socioeconomic status. So we have very developed cities, such in Beijing and Shanghai, and we have not so cities with not so high socioeconomic status. For example, we pick up a hospital from Xinjiang and hospital from Lanzhou. So we aim for a good representative of geographic and socioeconomic status. And for patient characteristics, the main study will, the patient information will be collected by questionnaire, and there's a long list of questions we collected. So for example, we collected social demographic characteristic of patients, including age, sex, marital status, education, a detailed information on income and insurance, and also some clinical characteristics. They are important for patient prognosis. And then the study outcomes. There are 3 parts of study outcomes. Clinical outcomes, for example, whether the different types of procedure impacts the patient's chance of convert to an open surgery. And this does not apply to the open surgery. Length of operation, length of hospitalization, post-operative complication, etc. And the pain indicator. And the second part is health outcome. One of the most important is the quality of life, which is measured by a standard instrument, the EQ5D5L. And for example, the patient pre-operative anxiety. The thought of this question is patient may be very anxious if they are going through an open surgery with a huge cart, but maybe they are less anxious if the surgeons told them, oh, we just need to maybe 1 hole or 3 holes on your abdomen. So maybe there are different level of patient anxiety, and that certainly impacts patient's quality of life, etc. And an important part of the questionnaire is about causes. So we collected direct medical causes, for example, in hospital expenses incurred by the disease and the surgery, out of hospital expenses, and the direct non-medical causes. So patients may have to, for example, travel from other cities, and they may have to stay in a hotel, they may have to pay for nutrition. These need to go into the cost, and they will be classified as the direct non-medical causes, and also indirect causes. This is actually a more interesting question. So patient may suffer lost productivity due to missing work or premature death. And there's a thought that with robot-assisted surgery, because of its better precision and potentially better patient outcome, patients may go back to work earlier, and they may have a higher productivity. And this part of the increased productivity may sometimes outweigh the causes, the high initial causes associated with robot-assisted surgery. And this part is hard to measure unless you do an active patient follow-up. So we are very excited for this. We are very excited to see the outcomes of this part. And another challenge about collecting cost information is cost could be difficult to measure, especially if you rely on patient recall. Unfortunately, the National Health Security Admin, they have a portal. So for example, if you are enrolled in the National Health Insurance Program, you can log in to either the website or download the app or connect from the WeChat or Alipay portal, and you can log in using your information, and you can have very detailed and accurate information on your healthcare, on your health expenditure. And we will rely on this portal to collect the information, collect the medical expense information. Okay, and a potential advantage of the robot-assisted surgery is it may provide better surgeon comfort. In the conference, a surgeon from Shanghai was joking that he now could perform the surgery over a cup of coffee. And this could have good potential because it may improve surgeons' productivity and may extend a surgeon's career lives. So for example, this is an example of laparoscopic. The surgeons have to hold the tools and he has to do the repetitive movements for an extended amount of time. And this could be uncomfortable. And this is the example of a robot-assisted surgery. The surgeon could sit on a console, maybe over a cup of coffee, and perform the surgery. So we thought that this could be also a very interesting outcome to exam. So in the study, we collected surgeon comfort level using a standardized tool called local experience discomfort scale. Okay, and this is the patient follow-up schedule. It's an ambitious and a lot of work. So after a patient is hospitalized, after is adamant and the surgical approach is determined, we do the baseline, we do the patient enrollment and collect the baseline information. And then after surgery, we have 3 years of follow-up. We will do a visit at 1, 3, 6, 9, 12 months, and then have every 6 months after between the second and the third year. And the schedule was made according to the clinical guideline. We are hoping that since this is consistent with the clinical follow-up guideline, we may have better patient retention. Okay, and this is the analysis. It's a toy example compared to two economists model. And I would like to emphasize the incremental cost-effective ratio. So this is the ICER. So this is the threshold. For example, the reimbursement agencies and WHO use to decide whether certain policy, whether certain medication or technology is cost effective. For example, according to WHO, if the ICER is below 3 times of per capita GDP, it's considered, oh, it may be worth pursuing. If it's below 1 per capita GDP, is a very cost-effective intervention. So for the to calculating the ICER, we will calculate the differences in costs and difference, yes. So this will calculate, for example, per quality of life adjusted life year gain, how much money you need to expend. And as we say, if it's below, for example, 1 per capita GDP, it's very cost effective. And it's an intervention that is worth, for example, including in the health insurance and be reimbursed. Okay, in real world studies is great. You collect the real data from patients in real clinical world, but it's very costly and time consuming. We have done more than 1 year of preparation and we still not yet collect data yet. So in the past year, we have a collaboration, building the collaboration network. So for example, for the 16 site, we have built a connection. We have signed the agreement with 9 of them, and questionnaire revision, patient follow-up system building, ethics review, researcher training materials, etc. So it's very time consuming and costly. But we think that all the work may be worth it as it represents the largest of its kind globally for health technology assessment of robot-assisted surgery versus a more traditional type of surgery. And with the project, we aim to establish an empirical foundation for policymakers in formulating relevant pricing and reimbursement policies, and for maybe investment utilization and management of equipment within medical institutions. I don't have the data yet, so maybe hopefully next year or 2 years from now, I can bring the results back and share with you again. Okay, with that, thank you.
Okay, thanks a lot, Bailey. I think now we are going to proceed to a Q&A session, right? Any questions from our audience?
And this question just pops up to me when you were talking about like the patient follow-up, and I was wondering, will we be assessing like how well the patients how well they accept robotics in assisting surgery, because it is like a very unconventional way of doing surgery?
You mean like a patient preference?
Yes.
Yeah. So in the study, not in the questionnaire part. So in the study, since this is an observational study, we don't, for example, we don't intervene on what the procedure a patient may receive. So in the current study, for example, which group a patient may join is based on mutual decision between the patient and the surgeon. So for example, a characteristics that may influence their decision is their socioeconomic status, because the robot-assisted surgery is more costly. So for example, patients with higher socioeconomic status may be more likely to choose that, or they may have higher preference of safety or precision. So we don't. But I think your question is a great question. So patients' preference for this new, for example, the health innovation, what's their preference, and what may, we would like more detailed information about how, for example, the mechanism, what factors may influence their preference. And for this part, we're planning to do a more qualitative study, for example, in-depth interview with them. And this way, we probably will know more detail about what may influence their preference, what concerns they may have. But yeah, thank you.
Okay, thank you very much.
Professor Lei, thank you for your share. I have one question. Maybe I think after the implementation of PCP, the elderly people have better access to obtain the labor market information. So maybe their labor supply would be improved. So their health outcome would be also be, maybe, I think maybe labor market would be an important mechanism. So yeah, have you checked this potential mechanism?
Okay, thank you. That's a very good question. Labor market outcome may be one of the channel if the sample is younger, but for this sample, those are people who are 65 and above, and the average age is more than 80. So the labor market outcome may not be important for this sample. However, still in the rural area, you are right, probably that may change their behavior, because in the rural area, people actually work until they die, probably like that. So we also look at the income. So one of the channel we check is the income, and it does not change significantly about the income, and also family transfer. So not on their own labor market outcome or transfer from their children. So that we already checked that. Thank you.
Thank you.
I have a question for the second paper. I think that's very interesting. Thanks for the presentation. Regarding the details of the innovation policy, can you bring up more details to explain how this large shortening of innovation time that happened during that period? I mean, I remember, if I remember right, is a large shrink of time from like 500 days to 100 days, right? So I'm wondering what actually happened there to magically shorten the time that much.
Right. I think that's the question that we have in mind when we study that policy. And we've been trying to find some documents from the news or from the government documents, and also talk to the people who were there at the time of the reform. So I think the short answer that we got, and it's also something that I briefly mentioned in the presentation, is that the collected user fees, the exact number, I think it's like 19,000 Chinese yuan, if I remember correctly, for one application. And they use those kind of collected user fees to recruit more evaluation staff. And actually the exact number is, I think at the time of the reform, they only have 70 evaluation personnel. And I think after 3 years, they increased the team size to 800. So that's almost like a 10-fold increase in the size of the evaluation staff. Right.
Have you checked the rejection rate or approval rate?
Yeah, I think we checked that. And I'm only showing our main results on like the number of R&D applications, basically the number of applications that people like want to go into clinical trials, right? We also check the results on the number of stage 1 to 3 clinical trials, and I think the finding there are similar. So basically, there are more applications
Yeah,
and
so
there
the
are more.
number of applications may stay the same, but maybe they want to accelerate the process. They approve more cases, or they just reject those without thinking more details about it, because they don't have that time for think about that in more details.
Right. So basically, you're concerning about the quality of those applications, right?
Yeah.
Whether
Since
they're more
basically,
risky or stuff.
I remember someone brought this up during your presentation. So basically, a similar idea. The sample composition may stay the same. This might be the kind of companies or the application qualities. Well, the qualities change as well. I mean, the sample composition may stay the same, but the acceleration may change the approval rate. So that may in turn stimulate different firms to apply for this approval process.
Right.
You know what I'm talking.
Yeah. So the approval rate, I think we might have checked, but I don't have the like what the result exactly is on top of my mind. But like related to your quality concerns, so the reduction in approval time is not the only dimension of the reform. So together with trying to reduce the approval time, they are trying to also like probably, for example, enhance the penalty for data falsification, and also I think another thing is they establish some very clear standard for people to submit applications. For example, one of the complaints that people often make before this particular reform is that sometimes they don't know like what the government agency is looking for, right? So sometimes that creates room for like corruption or something, because people need inside information from the government agency to know what they are looking for and what their position is in the queue. So now they make everything clear, right? And also before, there's a lot of like very falsified or substandard applications waiting in the queue, and that's wasting a lot of time of the government stuff. So now I think they have made it clear that if we detected that there's issue with this application, especially with falsified data or substandard stuff, then we're gonna like not to let you submit any application in the next couple of years or so. So in general, I think people think this reform has improved the quality of the applications. So I think, yeah, but those kind of like composite reform measures, sometimes it's hard to quantitatively measure, right? So we are choosing this particular aspect of the reform, which is the reduction of approval time. But actually, I think we are evaluating like a composite reform that is not only reducing the approval time. Thanks.
So thank you to all our three speakers. I'm going to convey some questions from our online audience. So for the first study, one audience member is interested because of data constraints. It stopped around 2018, I believe, and he's asking what might have changed since 2019 in that respect. And another question for the last study, Professor Liu, are there any similar research about open surgery in the US? Were there MOE robots installed? And a second question, are all 16 hospitals selected public hospitals, and does the data collection for patient expenditure include any self-paid patients?
So the policy was between 2014 to 2016. So they were wondering what happened after that, right? So I do not have information on that, but actually our data, the policy started in 2014, and as we just showed in the introduction, actually the internet access increased a lot even after 2018. The reform started there, but it built all those infrastructure and the services, and in the following years, still more people actually had the internet access, even after this BCP event.
Okay, thank you for the question, and thank you for letting me know about a similar study in the US. I would love to check more details about that. And about the hospitals, yes, of the 16 potential 16 hospitals are public hospitals, and they are basically leading hospitals in the regions. We know that this could have issues in the generalizability, but we are more concerned when we were selecting the hospitals, we were concerned about, for example, when even in health technology assessment of, for example, the surgery, the learning curve could matters a lot. For example, if the surgeons are very skilled in performing the surgery, the patient outcomes and maybe the causes will be very different compared to a beginner surgery. So we would like to, for the study, we would like to focus on hospitals. They are skilled enough. So, for example, the outcomes, the potential outcomes among these 16 hospitals are more likely to be comparable. And the penetration of this new advanced technology usually first happen in leading, for example, tertiary hospital, and then gradually to maybe more secondary and more rural areas. But so far, I think the utilization of this advanced robot technology, most of them happen in tertiary hospital, and that's another reason we choose the public, the tertiary hospitals.
I may add something about the first question, the question for my paper. After why we didn't use the data after 2018, I think that may be the question asked about, because this is a panel data, and also those people are old. So if we use too longer wave, there will be very few people left. However, we also use 2021 to capture some like the mortality information from there, because each wave we ask whether the die in the previous few years, and if the died when. So we actually use some information from later wave, but again, because those people are more than 80, average age is more than 80, so we cannot use too long wave, and we want to use information before the policy and after policy.
Yeah, there's one last quick question for Professor Lei, and so I'm curious, like how about more detailed mechanisms on our findings, and is education an important interaction term for your result? Like people might find hard to use internet, right? Especially those old and uneducated people.
Yeah, that's very interesting question. And we also wanted to know when we did the research. That was why we tried to investigate all of the information that we had in the data. And we tend to think that the mechanism is more like from the community level services that provided after BCP, because they built those infrastructure, internet access to people including urban and rural areas during that period, the community can provide all sorts of services, maybe including telemedicine, consulting, and all those things. Because as you said, it's really hard for elderly people to use those internet by themselves. So the community level, at the community level, some other people can use the internet to help them to access to all sorts of services that may help them. That may be explain why we didn't find effect at the individual level much, the behavior stuff, but more from the community level. At the individual level, we do find some like social activity stuff that is consistent with the finding that the community level also provides some social connection, social activity provision. So that's what we think probably is the main channel.
Thank you so much.
Sorry, I have a question for Professor Liu. It's about the HTA, about the surgical robotics. So from my question is about the threshold for the ICER. Yes, so I wonder like how do you determine like which is the appropriate threshold for the ICER and to evaluate whether this device is effective or not? Like cost effective or not?
Yes, that's a very good question. And I mentioned there are different ones. So in WHO, there are basically three tiers. If it's below 1 per capita GDP, it's great. If it's between 1 to 3, it's good. And if it's beyond 3, it's probably not so cost effective. But actually in practice, whether it's 1 per capita GDP or 3, it depends on the context. For example, if you are in the UK, you may have a higher threshold. And in China, for example, the current medical insurance, so you know all the innovative drugs, they have to go through the price negotiation. And the current threshold we use is usually 0.8. So it's only 0.8 per capita GDP. And you know in US, it's illegal to use ICER, for example, for reimbursement policy. So I think it depends on the context and depends on the resources a country have. And to some extreme, for example, in the US, they don't use that. They think it's illegal and is maybe not ethical at all. Yeah.
Thank you. Okay, Professor Lei, I have one more question. So why did you not use Chang's data? Charles. So yeah, the elder people would be younger. Then you have 2 waves after the implementation of PCP after 2016.
Yes, for child's data, yeah, of course, I considered child's data because I was one of the person to help conducting that data set. But you know, like in this for this policy, we want to use the city level policy, and there are more than 100 pilot cities who conducted this policy. But for child's data, the total city was only 150. So if we merge, we may find only very few of that were in the sample. But for CLHLS, we have about 500 cities there. So by doing that, we can merge enough cities to have that. And one additional thing is that for child's data, actually they do not release the very detailed information about the county, city, those detailed one. Even if I am within the research team, it's really hard to get that from Professor Yao Hui Zhao to do that. But the key reason is that we have more cities in CLHS. And the third reason is that we care about the elderly people and we care about mortality. That is a very unique outcome. We can do, if we have a child's data, it's only 45 and above. Unfortunately, or fortunately, each year we do not have enough mortality to do that. But for CLH data, we can have enough sample of mortality to do those analysis.
Thank you.
Thank you.
By the way, Charles is the China Health and Retirement Longitudinal Study, for those of you who don't know. Maybe time for one final question?
Yeah, so there is a question, a follow-up question online, okay, addressed to Professor Liu, I think. So the question is about, in your experiment, okay, how will you collect the self-paid patient expenditures?
Oh, yeah. So we did not so for one eligibility criteria is the patient have to have the national insurance. They have to be enrolled in the national insurance program. So we can access the portal and have detailed information about the medical costs. This is certainly a limitation, but yeah, it's a trade-off when we're designing the study. We may lose, but given the high percentage of patients enrolled in the National Medical Insurance Program, we think we won't lose a lot of patients, but it's certainly a trade-off.
Okay, thank you so much. Yeah.
Thank you very much. Please join me in thanking our 3 distinguished panelists and our moderator, Professor Pan. This concludes our webinar. Thank you all very much.